Thanks so much for joining us with HIMSS TV. I'm Laura Levitt. I'm the managing editor at Moby Health News. Today we have with us the team from the MIT COVID-19 Challenge. We have Alfonso Martinez, Dr. Freddie Nguyen, Paul Cheek, Stephanie McConnell, and Eric Yane. Thanks so much for joining us. Let's just start off a little bit about the COVID Challenge and sort of how it came together.
So I can jump in really quickly here in talking about how it all started. About 3 weeks ago, when the COVID-19 crisis really hit, myself and a colleague started looking at how can we make this time that we're going to be spending at home useful for the crisis? How can we have an impact on the crisis? And we started developing a solution, like a digital solution, but we realized that we were facing key problems. We didn't know what specific issues of this entire crisis we should be tackling. And we didn't have any partnerships in place to scale whatever solutions we would put together to get them into market and to have a tangible impact on this COVID-19 crisis. So in my previous life, before coming to MIT as an MBA student, I helped organize some hackathons, and it came to mind, a hackathon could help this. A virtual hackathon could help with identifying the key issues that we really need to tackle, as well as establishing that set of partnerships that can enable any solutions that are quickly put together to go to market really quickly and have an impact on patients that are most needed in this crisis. So I reached out to Freddie, and Freddie has been the co-director of this group called MIT Hack in Medicine for many years now. And I essentially was like, hey, this is a no-brainer. We need to put together this virtual hackathon and see how we can enable this huge amount of people that have right now an eagerness to have an impact on this crisis, but feel idle and helpless in not being able to do so. So Freddie was like, yes, let's do this. And in a matter of, I want to say 48 or 72 hours, we had the entire MIT community, as well as the broader healthcare and technology community in Boston and nationally, supporting this initiative. So the concept of the MIT COVID-19 Challenge came about. And we were super blessed to have the support of individuals like Stephanie, Paul, and Eric to build a really strong team to make this initiative happen. And what we thought of was building a series of virtual events that could enable individuals that were looking to help in this crisis, all from very different backgrounds, come together and work towards the specific issues that were most pressing at this point in time. And not only work on the specific issues that are relevant today, but also work with the partners that can put those solutions that they develop into practice.
Yeah, it's interesting. I think it was at 7 different tracks, right, that there were to kind of go through. I'd love to
10 tracks.
10 tracks. Okay, I just got to G. That's what I was. So I'd love to. Yes, I would love to go through those 10 tracks, and then a little bit of the thinking behind those tracks. So why were those important, and sort of what was the need for each of those?
So the way we source the tracks or the different things is we actually started off with 2 main areas, and that really came from the people that were involved on the organizing team, focusing on how do we protect the vulnerable populations, and then how do we best help health systems. And what the strategy we took is because we knew that unlike the other hackathons that Hacking has traditionally done in the past, and that others have, we probably would not get the propensity of the healthcare workers and providers, the frontline workers who know about all the problems that they're facing. And so we decided to partner up with a series of clinical partners from across the country, including Mass General Brigham, the National VA System, Oregon Health Sciences University, Universal Health Services, Weill Cornell Medicine, and Johns Hopkins University, to really be our eyes and ears to find out what those problems are that they're facing directly on the front lines. And not just sourcing those problems, but helping synthesize and prioritize those problems. So that way we can hand them off to the participants to really be acting around problems that are pressing right now, as opposed to what their perceived value, what they think the problem might be. And so the areas that we ended up focusing on came from all of our clinical partners and really covered a wide array. So, don't know if you want me to go through each of the tracks, or how do you?
Yeah, if you want to go through, just like a rundown of the 10 tracks, and then we'll get more into different solutions, kind of, that would be great.
Track A was on expanding and improving access to the COVID-19 education and resources. And really this was targeting the population of patients that either didn't have readily access to that information, didn't have internet access, didn't have means and ways to get that information that the hospitals or health systems were communicating. Second was about track B was on who to test and when, especially with the limited supplies that are available both on the testing kit side, but also on the reagents that are used for testing. How do you prioritize who gets that test, what frequency, what cadence to test as well, so that we can keep a better eye on the higher risk population. The third was track C, and that was about at-home patient triaging, and basically really focusing on how do we better educate but potentially enable remote diagnostics or monitoring processes so that we can keep the patients that don't need to come to the hospital to stay at home, and that only the ones that truly need to be seen in the hospital or have COVID-19 potentially to come into the hospital so they don't get unnecessary exposure, so to speak, especially since these are patients that would be at higher risk for even worse complications. Track D was on COVID-19 treatment and management. And here it was really targeting at the fact that there's not a lot of centralized and coordinated information from the health systems in terms of what works and what doesn't work, best practices, and much less having that information broken down into whether it's age groups or comorbidities that we can use to better triage the patients that are coming in, and that way we can better manage those patients as well. Because currently only about, I think, 60 to 80% of patients are supposed to only have are fairly asymptomatic or mildly symptomatic, and they don't need the ICUs and the ventilators that are in short supply. Track E was focused on the impact of social distancing and quarantines, and really getting at the fact that now that everybody was in self-isolation, work from home situations, other issues become more exacerbated, whether those are mental health issues due to loneliness and isolation aspects, whether that's quality of life, whether that's the mental well-being, but also thinking about the patient population who used to have essentially at-home care, healthcare workers come in, visit them, whether it's nurses to come and check on them and take care of their needs, or whether it's physical therapists, outpatient therapy, but other daily living types of things. How do we, continue to deliver that care, but yet not get them further exposed to healthcare workers who might be already at higher risk of exposure, so to speak. In the second category of helping health systems, especially dealing with all of the shortages in the staff and overworking of the staff, shortages of supplies and resources. So track F focus on identifying the COVID-19 immune. And here is really trying to figure out, can we come up with a system to better identify, who has been exposed, who is potentially has developed immunity towards COVID-19, and basically allow better ways for us to now see that who can be redeployed back into whether it's back into the healthcare workforce, or whether it's patient at large who have been exposed and can now be reintegrated back into society, back into the workforce, and so on. Track J was focused on new ways to deliver care in a COVID-19 world. And here it's, again, going back to the fact that now we're all isolated, restricted from traveling and going around and coming to the hospitals. So how do we still continue to take care of patients that, especially COVID-19 or not COVID-19, remotely now? And of course, this is where we thought telehealth, telemedicine might get a big boost, but are there other alternative ways besides just straight telemedicine as well that can be used to fill in those gaps? Track H was on hospital assets, coordination, and distribution. Really here, the pain point was the community has been really great at trying to support the health systems by pitching in, giving in donations wherever they could from their businesses, from their home, from their institutions, employers. But this is a really new situation for hospital systems to now be receiving sourcing from hundreds and maybe even thousands of different sources, and how to coordinate those efforts. And even once it's at the hospital, how do you then redistribute it within the appropriate areas of the hospital. Because hospital systems are usually used to dealing with maybe one, two, or at most three major suppliers for any of their equipment or supplies that they need, but now having to deal with hundreds of different inquiries or inbound requests has become unmanageable for them, especially when they're already strapped in bandwidth in terms of taking care of patients themselves. Track I was on space conversion, utility and projections, and really here has been the space where essentially as we're preparing for surges of patients that are happening across the country at our hospitals and potentially overwhelming our hospitals. I mean, we definitely know that our ICUs will be at capacity, if not overwhelmed. How do we now flex spaces within the hospital systems into new spaces that can see non-COVID-19 patients? Same thing with spaces outside the hospitals, whether they're in New York City. They've been doing this with hospital tents outside in Central Park, with turning the Javits Convention Center into contemporary hospitals and other places around as well. So thinking about how do we flex those spaces into now being able to take care of patients so that we can save the hospitals for taking care of COVID-19 patients. And also how to better predict these potential surges and how they'll manifest themselves as well. Because, even though a lot of us are focused on COVID-19, we still have non-COVID-19 patients that still require the same level of care that we provided before all this hit our healthcare system. And lastly, track J was focused on the healthcare workforce well-being, management, and training. And here is, as our healthcare workforce has been working basically 24/7 on this massive inflood of new patients and not knowing how to prioritize and triage adequately well enough, especially for a number of reasons. But really the goal here has been, how do we take care of the healthcare workforce on the front lines? Because right now we're going 24/7, 100 miles an hour, but we can't do that for weeks and months at end, which is how long we're expecting this crisis to happen. So how do we best utilize that workforce, making sure that they don't get overburdened? But secondly, as we shift around new priorities in the hospital, so for example, we cancel elective surgeries across our hospitals now, how do we redeploy that, whether it's the physicians or the nurses or the techs, to other parts of the hospitals that makes better use of their skill set? How do we enable people who didn't perhaps have a particular skill set on the clinical side to gain a small amount of new skill set so that it can enable higher skilled people to then be freed up to actually take care of the more pressing patients and urgent cases. And then lastly, as part of that is also to not just be thinking about the physical components, but the mental well-being of the workforce as well. I mean, this is just as highly stressful and overwhelming for the healthcare workforce as it is for patients out there. So
a lot of you have been sort of diving in and working with the groups, or kind of sitting in on different, all the different tracks. What kind of surfaced for you as some of sort of common themes, or even what were you really impressed by in terms of the winners?
I can chime in on my track specifically. So one thing that we did was, since we had 10 tracks, we had track leads. And we had essentially track leads and track teams to work with about 150 people per track. So one thing I was going to mention earlier is that this initiative ended up receiving a overwhelming amount of interest, both from the participant side as well as from partners that supported it. We had 4,500 applications for this initiative, where we could only accommodate for 1,500, which was crazy. And we had over 500 mentor applications. We could only accommodate around 250. So this was overwhelming. And then we had about over 40 partner support. So we had a lot of people. So we had to split these people out. And specifically what I saw on track E, which was a track related to social distancing and quarantine, was the heavy focus on understanding how to use existing tools, existing processes, to redeploy them for those populations that are most vulnerable. And what we saw was a lot of teams coalescing around, how can I use this type of product or type of service that has been proven effective in other industries for this specific crisis? And one concrete example, for instance, one that I personally thought was incredibly valuable, and I was not thinking of this vulnerable population, was a team called Distance Domestic Violence, which is a team that was looking to optimize the process for which an individual that is at risk of experiencing domestic violence to be able to assess their risk of experiencing domestic violence, as well as outreaching for resources in a context where the potential perpetrator of such violence is also at home with them in a quarantine sense. So a population that's highly at risk and not well equipped to deal with it, they focused on how to use existing technologies and processes that have been proven in other use cases for this specific population.
Yeah, and I'll jump in. I think that one of the really unique things about this challenge is that we had people from every single time zone. We had 96 countries represented in the applicant pool. We had 49 states. And so the ability for folks to pull from their experience back home or that they've seen in other cultures and other geographies was super unique. And I know that there were a lot of participants that were nervous. There were a ton of participants where this was their very first hackathon, because most hackathons or challenges are in person and it depends where you're located. And this one was virtual. And so it was all over the world. And they were nervous about not being able to find teams. And so some of the most successful teams that I found in TrackG were teams that had never met each other before. They cluster around a certain idea set that they thought would be really interesting to pursue, and they found really unique solutions based on all of their totally disparate backgrounds. And one of the things that we've been trying to be pretty sensitive to is that no one knows whether this disease, like when it's going to end, how it's going to evolve, what it's going to look like in 2 weeks or a month and a half. And so what we wanted to focus on right now was the problem sets that the partners put forward, and then each track would kind of operate within that problem set. And so on track G, it was new ways to deliver care in a COVID-19 world. And so that's pretty broad. So at least in my track, we saw a broad range of solutions, and some of the winners were focusing on, like Alfonso said, how to use existing technologies, knowing that there's already such a deep constraint on the health system right now. So trying to put more on the shoulders of the frontline workers just wouldn't work. So how can we use existing tools like Team Immunocompromised on track G? They're looking to kind of utilize existing community platforms like Nextdoor and build on top of that. There was a team called Waitlist who know that the waiting room is a really dangerous place for a lot of places, a lot of people. And so they want to create a digital waiting room, again, using kind of existing tools that can plug into the system at hospitals. Agora Health was trying to find a way to onboard a lot of these physicians and practitioners that are currently isolated and their practices are closed. So how can they quickly and easily onboard them to telehealth so that they can continue their practice and people can continue getting care? And then another was Mental Health Coverage Now, that are looking at the vast array of people that are losing their jobs right now or being cut back on hours, and as a result losing their mental health benefits. And right now that's probably the worst thing that could happen to folks that are in need of mental health. And so it was a really broad range, at least within track G, and the way that these teams from totally different backgrounds were able to come together to come up with some of these solutions was really, really inspiring.
Yeah, and I think we saw the same thing in track A, also like very broad kind of problem statement. But another thing is, Stephanie, you mentioned a lot of people who didn't know each other forming teams, which is excellent. But we also did have folks, even from our partners and other companies, that sent teams to work together. We had a group from BCG Digital Ventures that was all around the world, all collaborating, bringing the experience of their jobs, but also their cultures together to solve problems, which was really amazing. And they didn't just leverage their existing network experience, they also leveraged their network. And what I mean when I say that is I saw a lot of teams conducting vast research on the problems that they were going out to solve and how best to do so. A lot of teams, even some of our students from here at MIT, we saw them go out and leverage their personal networks to find out what problems were the most relevant to solve. And in track A, which is all about expanding resources and education to those who are underserved, we saw a lot of projects that worked on preventing misinformation, the spread of misinformation or fake news, and how to kind of course correct for that. We saw a lot of people figuring out how to better support other members of our community, how to support the elderly with access to groceries and other necessities, and then also how to kind of facilitate the flow of money between individuals who want to make donations and NGOs or other members of the community who may need it most.
Yeah, it's interesting. You're talking a lot about different backgrounds. What did you see in terms of backgrounds? What were people coming in with for experience, and what did that look like?
And I'll say our participants really, again, that full spectrum of diversity, everything from, I think, correct me if I'm wrong, I think we've had people who are as young as 13 who applied into our hackathon as well. I'm not sure if they ended up participating, but and then all the way up into the 50s. So it's really the full spectrum. And I think the split even between students and non-students or essentially professionals is about, I want to say 40% are students and about 60% were professionals. And so that really speaks again to the diversity of the participants that are there. In terms of their kind of expertise background, also from all over the place, we had fairly good even distribution across the engineers and programmers, coders, to the user designers, to the business finance, to I was even surprised by like nearly 10% of the people were actually healthcare providers themselves that ended up participating. So I think that's one of the value proposition of especially this particular hackathon and the ones that we've done at MIT is it's about bringing all the stakeholders involved in the healthcare ecosystem together from the very beginning, where you start in the problem definition stage all the way through the code development of the solution together. And to Stephanie's point earlier about how these teams really formed around the problem, that's really the key thing here as part of what we do at these virtual hackathons and our hackathons at MIT is that is what is the driving force for all this. It's not about trying to find, an application for a piece of technology just because, it's fancy and nice and we wanted to do something. It's really about making meaningful impact on a problem that is a critical unmet need that needs to be solved.
Yeah, and what else I think is interesting about this is it's not just this one hackathon, right? So this effort is going to be a little bit longer. What is it going to look like in the future? What's kind of the whole scope of this COVID challenge?
So there's two parts of it. One is, as you pointed out, is that this is supposed to be, or was originally planned as a series of virtual hackathons, because one of the things that we directly recognized was how rapidly evolving the situation around COVID-19 is happening. That the situation today is very different going to be for the situation tomorrow. And so we wanted to ensure that we would do essentially a series of virtual hackathons where each one was hyper-focused on the most pressing challenges at that time and point. And so that way, a month from now, hopefully we're on to a new set of pressing challenges, either hopefully that some of the solutions coming out of this first one would have helped solve, or that other people have already solved and been on and tackling the next set of challenges. The other part is we had an equal focus on not just the hackathon itself, but what happens after the hackathon with these teams. So this post-hackathon pipeline and period that are going to be coming over the next few weeks are just as critical. And this is one of the reasons I would decide to recruit such a wide network of partners as part of the coalition we brought together to support this initiative, is because we wanted to ensure that we had entities that had the expertise and the resources that we could very quickly activate as soon as we knew more about what the teams were going to be working on, what the teams are going to need, because there's no time to be wasted at this point. We didn't want to wait until after the hackathon, once we figure out what teams continued and what they worked on, to then figure out, okay, who's the best person to then tap for that, or the best entity to tap for that, and then try to forge those relationships. So we kind of de-risk that situation by bringing all those things up front before the hackathon. And this was also the same reasoning with why we struck these partnerships with our clinical partners too, is because, one of the things we task with them is, let's take a look at your implementation pipeline right now and your pathways and seeing, where can we streamline and optimize, where can we remove the unnecessary hurdles that were normally in place, simply perhaps as gating functions, but and bring those up to the front so that at least when the teams are designing their solutions, they're designing them already knowing what the constraints are in place that are either unsurmountable so that they can address those right up front, and not waste any time when it gets to the implementation and kind of porting their solutions over into the end users.
Great. And is there anything I haven't asked yet you think is important to add, either about kind of this hackathon or sort of the challenge in general?
I think the main point I wanted to reemphasize, and I think Alfonso brought this up earlier too, is really how quickly this initiative got pulled together. As Alfonso mentioned, literally within a few days of us calling up on our various networks and partners. And it was amazing to see how quickly like the organizing team mobilized behind this effort, that the various groups within the MIT community, both from the student side, the non-student side, the departments and and centers within MIT that were supporting this initiative, I think has been phenomenal, because we definitely wanted to bring the MIT community together towards this challenge, but we definitely wanted to bring the whole ecosystem together. And I think that's really exemplified that we have strong representation from not just clinical partners, but our industry partners, whether it's big pharma, big tech, to incubators and accelerators, essentially. And so that, I think, speaks volumes to what our vision was for this, and that we as a community, as a ecosystem, can tackle together.
I'll add on to that quickly. When Freddie and Alfonso came to myself, Bill Aulette, and the rest of the Martin Trust Center to get MIT backing for this, they'd clearly just come up with this. They already had a vision set, and they already had 41 people signed up for something that didn't even exist. And I think that really speaks to not only their vision and their drive to make this happen, but also the participants. They didn't even know what they were signing up for, but they wanted to help. They wanted to make a difference and support the COVID challenge.
So in terms of like concrete output, I'd say things to remember or things to note of this weekend is that in less than 48 hours, we had 238 teams from literally 96 countries all over the world, all over the US, 49 states represented, work on 10 key issues that are all relevant to key stakeholders in the healthcare ecosystem here in the US and globally.
Definitely. And the momentum that from when Alfonso kind of had this idea came to Freddie, me, Paul with this, and we were able to kind of like mobilize in 4 days this ideathon. The momentum and the outpouring of support has been overwhelming. And I think what we would like to do from here, there's still a lot of people that are reaching out, wanting to help and wanting to know how they can get involved. And this kind of tidal wave of support, we're hoping to channel and point that in the direction of our teams that have come out of this event. And so they need support and resources to be able to build and deploy and scale these ideas and these products and get them into the hands of the clinicians who need them and get them out into the world. And, we don't know what this disease is going to look like in 2 weeks or a month. And so some of these things can take years to build and to implement, and we don't have that kind of time. And so for the people that are still wanting to find ways to support this initiative, we want that support to go to the teams. And so if you have ways to help these teams build out their ideas and can help them get a POC off the ground and help them implement it and start making an impact as soon as possible, that's really, I think, where we're still very open to support right now.
Well, thanks so much for the update. And I'd love any other news coming out of this, what's going on with the teams in the future, that would be great. But yeah, please keep us updated, and thanks so much for coming on today.
Thank you, Laura.
Thank you.
Thank you so much for holding this interview, and we'll keep in touch for anything else that you might need.